To start the ball rolling, I will first ask Dr. Jayesh Tripathi sir that how can we define hyperglycemia in hospitalized patients and why it is important to diagnose hyperglycemia in hospitalized patients.
Sir, it is very important to diagnose hyperglycemic in a hospitalized patient for a variety of reasons. One is we are always concerned about critically ill patients in as far as their mortality is concerned in the hospital during a critical event. Second is long-term follow-up and complications and patient management. Whether the patient is a patient already of diabetes and has come, or whether he is a patient who does not have diabetes and has first time presented with diabetes, or alternatively, whether he has got stress diabetes. So depending on any one of these three factors, hyperglycemia in a hospitalized patient is very important, and anything over 140 is something which we should look at very critically. We don't want the hospital stay to be long, and we want to reduce the mortality rate. So all these three factors will play a very important role for us. Now the target, if you look at it, should be...
Sir, we will come to that. During the presentation, we will come to everything one by one. So this is about the definition and why it is important, because it is linked with consequences in the form of high infection rates, increased duration of hospital stay, and high mortality rates. And by managing properly, we can reduce all these things. So the next question that I will ask Dr. Urman Bhai is how can we classify this hyperglycemia in hospitalized patients? And as rightly pointed out by Dr. Jayesh Tripathi, there is an entity called stress hyperglycemia. So what is stress hyperglycemia and why it is important to diagnose whether the patient is having stress hyperglycemia or pre-existing hyperglycemia or new onset hyperglycemia?
So we can say that there are three groups of patients which who get admitted to a hospital. One would be those who are already having diabetes, so diagnosed with diabetes, high HbA1c, high sugars, or already on treatment. So that is a group that we always encounter day in and day out. The other group would be those patients who are not diagnosed to have diabetes, but when they get admitted and with high HbA1c, we realize that they have diabetes. But the third and most important group is stress-induced hyperglycemia, where HbA1c is absolutely normal, but the sugar levels are high, especially more than 180 if it is a critically ill patient, or more than 140 if it is not a critically ill patient. So this is a group. Why do we give significance to stress-induced hyperglycemia? You cannot stamp them as diabetic because their HbA1c is normal. Number two, they may revert back to normal glycemia after discharge once the stress is over. The stress could be in the form of either a physical ailment or any infection or infarction or any surgery, anything. The important is in this group of patients, Mumtani et al., they came out with around 7 lakh patients trial. Those who were not diabetic, critically ill, and they realized that the mortality, 1 month mortality and the 6 month mortality was very high in those who were not diabetic and had only stress-induced hyperglycemia as compared to those who were diabetic or who were not diagnosed to have diabetes. So this gives us a clue that this is something which is a liquid state where there is excess of catecholamines and hormones, there is excess release of inflammatory cytokines, and that's why this is a group of people who should be taken care of very, very critically so that we can prevent the high mortality. So stress-induced hyperglycemia. And the trial suggested that especially those patients who had neurogenic diseases, those who had head trauma, or those who were in coma, they had highest mortality amongst all. So whenever we see stress-induced hyperglycemia, we should become alert, we should pay more attention, and we should be critically analyzing the whole data and keeping an eye on them, because there is going to be a long hospital stay, there could be very high mortality, and there could be more chances of complications.
Okay. Thank you, sir. So this gives you a clue that stress hyperglycemia, which is directly related to the severity of the underlying illness, is also very important and can give you a clue about the overall consequences which are related to the primary illness. So now I will go to Dr. Revati Iyer, madam, that how will you treat hyperglycemia in hospital settings, and is it different for patients who are admitted in critical care units and patients who are admitted in non-critical settings in wards or other things? Is it different for two categories, or is it same for everyone who is being hospitalized and the same protocol will be followed?
Yeah, this is very close to my heart because I had a critical care unit of a corporate hospital. So, patient in a non-critical care sitting would probably warrant a routine basal with a bolus which we are routinely giving, or change them from a OHA to basal plus bolus. But in a critical care setting, the patient is very sick. Usually the patient is on inotropes, patient is on maybe steroids, patient may be intubated on ventilator, the nutrition may or may not go. So in those cases, we prefer to give insulin IV, preferably in an infusion form, to maintain a normoglycemia, and the target is 140 to 180. We never target less than that usually, because hypoglycemia is probably more detrimental to the patient than hyperglycemia.
Okay, thank you, madam. So the treatment will depend on the settings in which the patient is being admitted. Critical care settings is different, and non-critical care settings or wards, it is different. Basal bolus versus intravenous insulin infusion. So now I will come to Dr. Aarti, madam. So what are the broad targets for blood glucose in hospitalized patients, and can you summarize few of the landmark trials which are supporting these targets?
So there have been a lot of trials, but the most important I feel is the NICE sugar trial, which had more than 6,000 participants. But in a gist, all these trials told us that liberal glucose readings maintenance is equal to the stringent. The stringent glucose control does not give any extra benefit over the liberal. So that is why the levels are now said to be liberal, better than the stringent. So, as Madam said, in both the conditions, in the non-critically ill and the critically ill conditions, there are set targets. In the non-critically ill, we go by the 3 levels: fasting level, the pre-meals, and the post-meals. The fasting should be less than 120, the pre-meals should be less than 140, and the post-meals should be less than 180. And in the critically ill, as Madam said, it is 140 to 180. It should not go below 140 and should not go above 180 at any time.
Okay. Thank you, madam. So this was about the basics of in-hospital management of hyperglycemia. Now we will start with first critically ill patients in the ICU. How can we manage? And these are the objectives that we keep in our mind whenever we are treating hyperglycemia in critical care settings, that is restoring stable glycemia, minimum disruption of the metabolic state with minimum adverse outcomes, also focus on hypoglycemia. So first I would like to start with Dr. Jayesh Tripathi. What are the prerequisites for starting intravenous insulin infusion in critical care settings, and what are the various protocols for IV insulin infusion? Over to you, sir.
For majority of the critically ill patients, we have to give IV insulin. We have to give IV insulin to control the hyperglycemia. The earlier you control it, the better it is. I have a slight thought here that all these trials and all these things that are going on, but all of us have experience in day-to-day life that ultimately customization from patient to patient, depending on the comorbid condition, is the bottom line. So that is one thing we have to keep in mind. The blood sugar, anything over 180 should be treated. Once IV insulin started, glucose should be maintained, as she said, Dr. Mule, that 140 to 180. And anything below 120 can, as Revati just said, that can cause hypoglycemia, which is even more detrimental. But in a few subsettings where the patient needs very, very tight control, like a cardiac surgery or valve surgery, or patients who are very, very fluctuating from very high to very low and all. There we have to keep a very close watch, and we try and keep a little less, say maybe 120, 30, 40. But otherwise 140 is to 180 is good. Now all the infusion protocols are safe and effective with low rates of hypoglycemia. You look at all the trials, and the exact protocol is probably less important, as I said. That customization is the key. What is important is presence in the institution, and you have a good infrastructure to manage these type of patients. You have a good follow-up, you have good facilities, then you can be more aggressive. But if a situation is there where you are in a peripheral rural center, where you have limited resources, there we'll have to take a little back foot, be watchful, and take care accordingly.
Okay. So I think message here is whatever insulin protocol you want to follow, you need to customize it according to your infrastructure, understanding of your staff, your medical officers, and overall your team. So it is a team effort, and not one protocol fits all institutions. Every institution has to customize given protocol according to their needs. That is the need of our management in critical care settings. Now I will go to Dr. Urman by that the patient is admitted in ICU, and now we have confirmed that we will have to start with intravenous insulin infusion. So how will you prepare and start IV insulin infusion? Most of the centers, they are having syringe pumps. So I will ask, if syringe pump is there, then by syringe pump. But suppose it is a very small center where syringe pump is not available, can we start IV insulin infusion by an infusion set? If yes, then how?
So that is the beauty of RSSDI, because RSSDI came out with guidelines which not only talked about the best possible setting, but also talked about the setting in a very small, having a very small infrastructure. This is how, in fact, we were treating our patients 40 years back with the help of IV fluid or IV infusions when we were treating diabetic ketoacidosis. So let's start with whether you are having infusion pumps or not. So then it becomes very simple that you can create 50 units of short-acting insulin, preferably Atrapid or any other brand you can select, and in 50 ml of saline, use it syringe pump, and then you can start with the help of that pump. What's the advantage of that? You can stop it anytime. Hypos, if it occurs, would not stay long because the insulin has a half-life of only 5 minutes. Third important thing is you are not pushing a lot of fluids. Because most of our patients, suppose diabetic ketoacidosis or post-operative patient, especially cardiology, would have a poor EF and they would not be tolerating a lot of fluids. So infusion pumps are very helpful when you want to restrict the fluid, which is the case in most of our critical care settings. So that way, it is one of the biggest advantage. So you can start using insulin infusion pump, which has now 1 unit per ml. You should, if you are using insulin pump, you should actually ideally flush out some amount of fluid, not necessarily 15 to 20 ml, but small amount of fluid should be flushed out, because generally the insulin has a tendency to adhere to the glass. So that portion would be rubbed off, and therefore there would be a uniform amount of insulin that you can push across different hours or different duration. So that is another thing that you can do. With infusion pump, you can adjust the doses within minutes. So suppose the patient has 80 or 90 blood sugar, you can immediately manage it. While in case of IV fluid that or the infusion pints that we are using, it would take some time, at least 5-7 minutes. So that is important for that. Wherever insulin pump facility is not available, still there we can go for using the 500 ml IV drip, where you can introduce 50 units of insulin. So 50 units in 500 ml would give you 1 unit in 10 ml. And then you can adjust the drip rate as per the Vacosette that you are using. Remember, whenever you are using this sort of infusion, that is through a IV drip, see to it that you do not use filtered IV set having filters, because that generally hampers the delivery of insulin. So ideally you should use the IV set without filters in these cases. Again, we have got three sorts of IV sets. You can have micro sets, you can have macro sets, or you can have, as rightly said, blood transfusion set. So in case of blood transfusion set, 1 ml would be equal to 10 ml, 10 drops. In case of macro drip set, it would be 1 ml equal to 15 drops. And then in cases of pediatric or micro drip set, which is also available everywhere now, there 1 ml would be 60 drops. So you can very easily calculate the amount of insulin that you want to introduce through the equation that has been given below, where you can write down the volume multiplied by drip factor or drop factor divided by time. So, for example, if you want to give drip rate 10 ml per hour, in case of 50 units in 500 ml, that would deliver 1 unit, right? So, if you want to deliver 1 unit, as has been written there, per hour, you require 10 ml of the IV fluid, as can be seen per hour, which is not excessive. But the more insulin that you want to deliver, suppose you want to deliver 7 units, in that case, you require to give 70 ml per hour, which may be a little bit higher. So, if you require a smaller dose, IV fluid is fine. If you require larger dose, either you should shift to infusion pump or you should shift to higher concentration. So instead of 50 units that we suggested, you can introduce 100 units. But here again the catch would be chances of hypoglycemia would increase if you do not have proper infrastructure which can exactly control the IV fluid rate. So the best is always the infusion pump, but there are options or the alternatives that are available, and it's very easy to use. How do you start it? So always, if the blood sugar is more than 300, give a bolus dose of 0.1 unit per kg body weight. So a person having 70 kg weight, you can directly give 7 units of insulin directly without hesitation if the baseline blood sugar is more than 300. And then again another equation that would give you the baseline glucose 200,
Current blood glucose by 100.
by 100. So suppose 250 is the blood sugar at the time of initiation of infusion. You can divide it by 100 and start at 2.5. The catch is always remember to monitor frequently, as we'll be talking in the next question. But there is no science. It is an art, and the art says monitoring, frequent monitoring that can only help you to control the sugars without causing harm to the patient.
Thank you, sir. So this was about how you will start infusion with a pump or an infusion set and what will be the starting rate. So I will now come to Dr. Revati Iyer, madam, as she is treating a lot of patients in critical care settings, that how will you adjust this insulin infusion rate?
Yeah, like how do you start? That has already been discussed. So normally what we do is once we started it, we monitor the sugar hourly initially. So initially we monitor the sugar. We can see the current blood glucose, the previous one, the insulin infusion, the rate of change or the how much is being changed. Like if the blood glucose is same, then you can, that is it is not coming down, you have to increase the infusion dose. If the blood glucose decreases by less than 30% from the previous CBG, then you have to again increase the infusion rate. But the blood glucose decreases more than 30%, then you continue the same infusion dose. You have to basically maintain a blood glucose less than 180. The target is 140 to 180. So this is a little complicated, but basically the inference is like already they have said, say if it is 300, you can start with 3 ml per hour, 3 units per hour. So if the infusion, with the infusion, you are able to maintain a good sugar control as you wish to, you continue the same rate. If the sugar control is not adequate, then you increase the rate. So that is the gist of it. And say you can increase the rate by 25%, or if the sugar control is more, you can decrease the rate by 25%. Basically, as long as the sugar is above 140, you have to do all this. Once the sugar comes down, like, if it comes down to say 110, and the blood sugar is falling fast, then you have to reduce the infusion rate by about 50%. And once it comes down to 90, then you'll have to stop the insulin. And when it comes down to less than 70, then you'll have to give 25% dextrose. And the dose of the 25% dextrose is calculated as 100 minus the blood glucose into 0.8. So, and once then you have to check the sugar, when it comes to 70, you have to check every 15 minutes.
I think hypoglycemia protocol, we will come to the subsequent slides. Okay, so thank you, madam. So the main thing is that you have to maintain sugar between 140 to 180. If it is increasing, then you have to increase the dose. Once it reaches 140, then if still sugar is falling, then you have to reduce the rate by 50%, and you have to maintain the sugar between 140 to 180. That is the dictum of controlling critical care settings. So now I will come to Dr. Arti madam, said that how will you monitor blood glucose in ICU during intravenous insulin infusion? Will you continue monitoring 1 hourly, or then you will increase the frequency to 2 hours or 4 hours?
So actually, before I start with this, 1 hourly glucose monitoring, I always think poor patient. Every hour we keep pricking fingers. So better to reduce the frequency as soon as we can. So we obviously start with that hourly, but as soon as we get 3 consecutive values in the target range, we can reduce it to 2 hourly, right? And that 2 hourly we can continue for 12 to 24 hours or so. If we get the target range, the sugar in target range, then we can switch to 4 hourly also. But there are some conditions in which we have to switch back to the increased frequency. Those are the conditions in which, say, the clinical condition has deteriorated, or we have initiated or stopped steroid or vasopressors or renal replacement therapy, all those things, or there is some condition with initiation or stoppage of the nutrition. So these are the conditions in which you have to increase the frequency. Otherwise, preferably if the sugar is in the target range, we can keep reducing it till we can start the oral.
Okay. Till we can shift to basal bolus therapy. Yeah. Okay. Fine. So the next question is to Dr. Urman Bhai, that how will you diagnose and manage hypoglycemia in ICU settings during insulin infusion? Because you have not only you have to correct hypoglycemia, but you have stopped infusion. That also you have to restart. So what point you will restart and how you will restart?
So the most important thing is most of the time we forget the basics. In critical care setting, there will be a group of patients who would be nil by mouth and there is no parenteral nutrition going on. If you are using an insulin infusion pump, you are not providing any fluid to them. Not only that, you are not providing basic substance, glucose to them. So always remember, patients who are nil by mouth for a prolonged period, suppose a post-operative patient or having GI pathology, and who are not on any parenteral nutrition, you must provide intravenous dextrose through some source. And the best option in these cases would be giving insulin in a DNS or dextrose containing pint rather than infusion pump. So that would be a caveat before using infusion pump, or while you are using infusion pump simultaneously, you must provide some source of glucose. Otherwise, these are the group of people who are very likely to develop either hypoglycemia or even ketosis. Not ketoacidosis, but ketosis. So, providing basic energy substance dextrose is a must. Otherwise, they would develop hypoglycemia. As I told you, there is no monitoring frequency. The best is monitor frequently if needed. Before we go on to this slide, another important thing is most of the time we are doing blood sugar through the finger sticks on glucose meter. Remember again, if the patient is in shock, these are not reliable, and therefore at least if you are doing it 1 hourly, at least a couple of readings should be sent to the central lab through the venous blood glucose. Otherwise, you will miss the hypoglycemia that we are going to talk. So, 2 important caveats: if the patient is on septic shock, severe hypotension, low perfusion, at least once in a while get a venous blood sugar done. So, once the blood sugar goes below 70, in fact, if it goes below 100, try to stop the infusion or reduce the rate. And if it goes below 70, obviously infusion pump has to be stopped, and you have to give dextrose 25% by the formula that has been told. That is the 100 minus the existing blood sugar multiplied by 0.8. So patient's blood sugar is 40. 100 minus 40 would be 60, multiplied by 0.8 would be 48. So around 50 ml of dextrose has to be given. Just giving dextrose would not be enough. You have to monitor again. And in this case, every 15 minutes till the blood sugar reaches 90. So most of the time in ER that we have frequently seen, the best of registrar gives the 50% blood glucose and goes to sleep. Well, you are going to be in trouble. Number 2, look at the insulin that is going on. If the patient is on simultaneously even a small dose of basal insulin, the hypoglycemia is going to persist longer. So you have to be careful. If blood sugar is more than 70, then check the blood sugar every 30 minutes. And once it reaches about 90, check it hourly. And once it goes above 140, you are back to the square, which means you have to start the infusion pump again. But always remember, patient would not have hypoglycemia symptoms in a critically care setting. So therefore, do not rely upon, you have to be very, very watchful, and therefore monitoring would be important. This happens very frequently at night, where a couple of sugars are fine and the registrar goes to sleep, thinking that if the patient would have some hypoglycemia, somebody would detect. It is very difficult to do it.
Okay. Thank you, sir, for highlighting the importance of monitoring and how to correct hypoglycemia and how frequently to monitor. So now I will come to Dr. Jayesh Tripathi, that the patient has been admitted in ICU, very well controlled with insulin infusion, now on a stable dose. So when will you stop insulin infusion and consider subcutaneous insulin therapy with or without oral anti-diabetic agents, or when will you consider shifting them from infusion to subcutaneous therapy?
Just to add to what Dr. Dhruv said, this 1 hourly protocol, practically when you are giving a bolus, or should be, we can do it even in hyperglycemia early, not only in hypoglycemia. Sometimes we need to do it a little early also. Then we can adjust. And the second thing is, there is no clarity on how quickly should we bring down the hyperglycemic states, 300, 400, 500, how quickly should we bring it down? That is another thing. So that is one thing which we have to think. Now transition from insulin infusion to subcutaneous insulin and what is, we have to follow the golden rule that the patient should not swing in the 5 sample, say pre-lunch, pre-breakfast, midnight. All these samples, you should not swing out of 140, 180 range initially. If the patient swings between in that range, then there is real trouble, because patient is stable on one hand from the comorbid conditions or the reason for his being admitted. On the other hand, he slips back into something more, like if there's a catheter there are tubes, he'll end up, if there's hyperglycemia, with more infections. So we have to be very careful on that. So anything over 180, or it is written 4 to 6 hours, but I normally would wait for 8 to 10, 12 hours. If the patient is stable for 12 hours, on most of the critical care fronts, if RAFT certifies all, ticks all the boxes, yes, now we can switch to the patient to subcutaneous insulin. And hemodynamically, stable without vasopressors. As he said about capillary, if you are still trusting the capillary thing, then the vasopressors will help you fluctuate that. And you ensure that the patient has started eating something. That is the time we will slowly taper the IV insulin and get into a subcutaneous model of insulin. And possibly think of his previous, if he's an established diabetic, if he's a previous accepted or a known diabetic, then we might shift to his oral hypoglycemics in addition to the insulin. So both these possibilities are open. The current lot of situations of oral anti-diabetic medications that we have, particularly with the SGLT2s and the GLP-1s, this SGLT2 business, sometimes we have to continue using in presence of cardiac and renal conditions. So there again, we have to take it with a pinch of salt, how to quickly add another anti-diabetic or insulin tapering. So these things we have to keep in mind before we decide to switch to oral anti.
Okay. Thank you, sir. So, transition occurs when the patient starts eating or is stable on stable infusion rates. So, transition generally is being done to
So we
insulin therapy.
can calculate the insulin when we switch from IV to subcutaneous insulin. Administration in non-ICU patients includes 3 components. As she already said, we can give a basal bolus, basal, or a little correctional insulin as and when, depending on the sugar. But remember, the patient has got out of the critical care. So there is no way that the first 72 hours, everything will respond as per the numbers of sugars. That will vary, and we have to be mentally prepared. I would rather keep a patient a little more in hyperglycemia initially for the first 72 hours till we are very sure of the nutrition and everything. Then only I would shift.
Okay. So now the next question is to Dr. Aarti Madam. I think this is the most controversial part of in-hospital management. Most of the smaller centers, either whenever they are admitting patients in non-critical care settings or in wards, they start with sliding scale insulin therapy. Or when they shift from intravenous insulin infusion to a sub-Q, they start with sliding scale insulin therapy. That is, if this sugar is this much insulin is to be given. But most of the guidelines, they say that to start with basal bolus insulin therapy. So why not sliding scale? Because it is very easy for doctor as well as for nursing staff to understand the sliding scale and follow the sliding scale. Is there any evidence that it is detrimental, particularly in non-critical care settings?
So, sliding scale, as you say, is used left and right in the non-critical setting. Everything said and done, because it is very easy and it can be started right away. So, despite all the evidence which has not yet, proved that the subcutaneous is good for us, but still it is being used because it is easy to order and easy to use. But because, as we said, there is no evidence as such, robust evidence in support of using this subcutaneous infusion, subcutaneous scale. So that is why it is better that it is not used. Plus, because there is no basal cover to keep the sugar in control at some level, it keeps fluctuating from very low to very high, and we keep, dodging between the two states. So this is the basic thing. And the more fluctuating the sugar is, the more detrimental it is. That has been proved always. So that is why it is better to use basal bolus regime rather than using a sliding scale.
Okay. So sliding scale is rather, we can say that it is a reactive approach, that you are reacting to sugars. Proactively, you are not doing anything to keep the sugar in range, whereas basal bolus is the proactive approach and more physiological approach to keep blood sugar in the range. So I would like to ask Dr. Revati Iyer Madam that why basal bolus therapy with or without correction bolus, why it is preferred, what are the evidences to support that we need to use this basal bolus therapy?
Yeah, basal bolus therapy is the more physiological way of giving insulin to the patient, the right type of insulin at the right time, the right amount, so that we aim to keep a sugar of say 120 fasting, 140 pre-meal and 180 post-meal as per our target. So that is what is the aim, and that is what we achieve by giving this basal to maintain a basal insulin and boluses to for combating the extra calories or the carbohydrate which are consumed during each meal. So there is a thing of correctional insulin therapy also. I think there are ways to calculate the correctional fraction, in which you calculate the total insulin dose, and then 1,500 you divide the total insulin dose and the value you get, by which you calculate the correctional dose, and that correctional dose you add to the boluses, so that you ultimately achieve a good control. So there are various trials, like as it's written, the Rabbit2 trial, which was done in medical patients, and Rabbit2 surgery trial, which was done in surgical patients, and this basal plus trial. All these trials proved beyond doubt that the basal plus bolus insulin therapy was much better compared to the, only the boluses, which we have been practicing since long.
So I think the message here is clear, that whenever you are using insulin in hospital settings, particularly non-critical care settings, it is a basal, which if the patient is eating, then nutritional bolus, which cover the nutritional requirements, which if required, then correction bolus. How can we use it? This is basal. This is bolus, which will cover the nutritional requirement, and then correction, which will cover the high glucose, which is their pre-meal. How to calculate and do this thing, that we will touch upon in subsequent slides. So this is a patient. What do? You have given him 6 units before breakfast, 6 units before lunch. Now at dinner, his sugars are high. So he will require not only 6 units, but also a correction bolus to cover that extra pre-meal sugar is there. So he will require 6 plus 2 units. That is 2 is correction and 6 is bolus. And that way you can bring down his glucose again to the range, that is 140 to 180. This is the way you give insulin in hospital settings. So now the crux of this thing, Dr. Urman Bhai, that how will you calculate the insulin dose when you are transitioning from infusion to sub-Q basal bolus insulin therapy? Or suppose a patient who is on a OPD basis and now you are admitting them in a non-critical care setting. So how will you calculate the initial insulin dose for that subcutaneous insulin therapy?
Right. So once again, before I go on to topic, I would once again give compliments to RSSDI, because we missed out one point initially which they had not missed. Always look for potassium.
Yes.
Right? Very important, because there would be intracellular shift if the blood sugars are coming from 400 to 200. So even the minutest details have not been missed by RSSDI. So always look for potassium levels at least once a day in a critically ill patient who is on insulin infusion. Coming to how will you calculate the insulin doses. So it's reasonably simple. What you require to do is first to find out the 24-hour daily requirement while you are switching from IV to sub-Q. Confirm patient is going to take enough diet, patient is conscious oriented, and you are sure within last 2 hours that he has maintained whatever is taken. So then you can shift IV to sub-Q. Remember, the half-life of insulin is very short. So if you stop IV insulin and then give you sub-Q insulin, there would be a time before the sub-Q insulin gets absorbed and IV insulin would stop working and the sugars would swing high. So always give sub-Q insulin before you stop the infusion pump, at least 2 to 3 hours prior to that, if you are giving the bolus, or even more if you are giving the basal insulin. So that is the first and foremost thing. Don't stop abruptly. Number two, as has been written, you decide the 24-hour requirement. That can be decided on the basis of 3 consecutive good stable samples and multiply by 8 by 8, or last 4 hours sugar multiply by 6, or last 24 hours sugar if they are all fine, and find out the total daily requirement of insulin. Again divide it into, as has been rightly said, 50-50. But before that, cut it down by 20% because the infection is controlled, hemodynamics is stable, renal function has improved. So it's very likely that the insulin requirement of the patient would go down. So within last 24 hours, if the patient requirement is 60, cut down it by 20%, that means you give only 48 units. If the last 6 hours are stable and the requirement was 12 units, so multiply by 8 by 4, so 48 units, cut down it by 20%. So before changing from IV to sub-Q, cut down it by 20% because the insulin requirement is going to be little less and we don't want to produce hypo. And once you have finalized the requirement, suppose it is 48, then divide it into 2 parts. 24, half of it is to be given in the form of basal insulin and half of it is to be given in the form of bolus. Bolus we give thrice with the breakfast, with lunch, with dinner. So again that half has to be divided into 3, 8, 8, 8. So if the patient's daily requirement is 60, you cut down 20%, 48 units, 24, 24, 24 basal, 24 bolus in the form of 8 units, 8 units, 8 units. So that is how you can proceed to go ahead with the insulin. When would you give insulin? I think, yeah. So if you are giving the Lentus insulin, you can give in the morning or in the evening, either time. Generally, we know that Lentus or Glargine has a 20 hours duration, so you can give it either in the morning or in the evening. But if you are giving it in the morning, check pre-dinner sugars. If you are giving in the evening, then check, keep an eye on fasting plasma glucose. That is very, very important. If you are giving a longer acting basal insulin, like Detamir, Degludec, which is 42 hours working. In that case, you can give it 1 time a day, either in the morning or in the evening. If you are not sure, you can give it even 36 hours.
Thank you, sir. So this is the example is rightly told by sir, that if the last 6 hours drip rate is 10 units, then you have to multiply it by 4, that is 40 unit, 80% is 32, 50% basal, that is 16 units of Glargine once daily, or if you are using NPH, then 8 units twice daily. Generally in hospital settings, it is better to use analogs because they provide better glucose control, less hypoglycemia, and if you are using bolus, then divide it in 3, that is also 16, so 5, 5, 5 regular or analog insulin with each meal. So now I will go on to Dr. Aarti Madam, that we have talked about correction bolus. So is there any formula to calculate this correction bolus insulin in hospitalized patients for good glucose control?
So this small amount that we give extra makes a big difference in reducing the time which is required to come to the normal level. So that is why this calculation of correction insulin is very important. So we can concentrate on the slide, that CF we have to concentrate on the right side of the table. The left side of the table has been covered. So that CF is the correction factor which we have to calculate first, depending upon whether we are using a regular insulin or analog insulin. So if we are using regular insulin, the correction factor will be 1500 upon the total daily dose. And if we are using analog insulin, it will be 1800 upon the total daily dose. And then whenever we are measuring sugar level, whatever is the sugar level at that point, minus 100 upon divided by the correction factor. That is the correction insulin, which has to be added to the preset dose of the insulin which we have to give. So as an example, say the total daily dose is 32 units. So we divide it into 50-50%, basal as 16 and bolus as 16. And at each time, the preset unit dose is 5 units, 5 units and 5 units to make it easy from 15 units to, so 5, 5, 5 units. Now, say because the total daily dose was 30, the correction factor will be 1500 divided by 30, that is 50 units, right? So the correction insulin that is to be given is, if the blood glucose is 250 at that time, so 250 minus 100 divided by the correction factor, that is 50. It brings us to the value of 3 units. So what is the amount of insulin to be given? The preset insulin dose is 5 units plus the correction 3 units, 8 units we have to give. So that is how that correction insulin is to be.
Okay, thank you, thank you. So this is a very simple formula. One important thing, if you are giving insulin to the patient and daily now you require a correction bolus, then you have to understand that your overall formula of insulin daily dose is wrong. You have to revise it. You have to revise both basal and bolus, so that our understanding is that less and less correction bolus should be required. More and more it should be a basal and bolus therapy. So I will now come to Dr. Jayesh Tripathi. How will you monitor blood glucose in these patients who are on a basal bolus insulin therapy in non-critical care settings?
See, just a thought, in those patients who have multi-organ failure and have come out of it. Second, those who are in the step down or recovery. If the patient is affording subset, I still would look for a CGMS patch.
Yes.
I still would look for a CGMS patch to monitor things better, much better, quicker and more effective, and without pricking the patient all the time. They get very irritated with this, I'm telling you. So first 24 hours after a transition are crucial to assess the patient's requirement. Hence blood glucose should be monitored every 5 times. But as I said, if a patient is affording, particularly those recovery step down unit people, multi-organ failure, multiple medication steroids, all these people, they do not eat well, nutritional status gets poor, intake out is poor, somebody is on dialysis, and they all give very tough time to Revati, I know. So these are the people I would preferably using a CGMS for affording, of course.
Okay.
So that is one thing. And
so I think this is a very good input, and I would like to ask even Dr. Urman Bhai also and other people also, that how frequently do you use CGM in your hospitalized patients for monitoring? Because this is really a very upcoming area where a lot of evidence is now there, and probably what new document which we are coming out in few months time from RSSDI about in-hospital control of hyperglycemia, we are going to deal that with a section related to use of CGM, when to use, how to use, and how to interpret, because these are 3 things which are important. So I would like to ask your viewpoints, Dr. Urman Bhai, Dr. Revati, and Dr. Aarti Madam. Have you used CGM in hospitalized patients, and what is your take on that?
In hospitalized patients, so far we have not used. Yeah, but in OPD basis patients and home monitoring we've been using.
That is okay, but
Yeah, but I think we should start using. I totally agree to it. Yeah.
okay. Urman Bhai, have you used it?
almost 30% of my patients are.
Good.
Yeah, we are using it in hospitalized patient, but again a caveat here. Remember, it measures the interstitial fluid, sugar. So in case of hypo, just whenever you are feeling that the patient is, double check with capillary glucose immediately. But otherwise, it gives you a very smooth control. There's a dictum again here that if a searchlight is moving around, if the caretaker's eyes do not follow the searchlight, there is no sense of searchlight. So if you are getting CGMS done, somebody has to be there to keep an eye over it. Otherwise, at the end of 3 hours, you realize that there was 70. So alarms should be properly maintained and alarms should be followed. So with proper resources, with proper person to follow it, CGMS is going to be occupying the critical care units in next couple of years.
So I agree with them. I think it is coming in a big way. The only thing is we will require training of medical officers, staffs and everyone, that how can we use it optimally for better management of people in the hospital settings. Relatives also. So let's come to Dr. Revati Madam, that what about transition to subcutaneous insulin therapy? Suppose somebody is having stress hyperglycemia, HbA1c is normal, and he was on an intravenous insulin infusion, and now he is being shifted to a ward completely recovered. then will you transition it to a subcutaneous insulin therapy or to OADs, or when will you think of like in stress hyperglycemia?
Yeah, basically, mostly what we are seeing is many times what we see as stress hyperglycemia is probably, yes, stress hyperglycemia, could be steroid induced hyperglycemia, or it could be just a first time detected diabetes. And they don't know about it. Yeah, HbA1c, yes, maybe has been normal. Anyway, if the sugar persistently remains more than 180 and the patient had required more than 1 unit per hour of IV insulin, then it would be necessary to monitor the blood glucose levels and institute sub-Q insulin so that they do not end up in hyperglycemia in the wards. They are still not out of blue. They still have some infection persistent. So we need to continue sub-Q insulin. And maybe if they are going home, we might have to transition them to some oral antidiabetics also. If the patient is on a normal diet, he doesn't have ketoacidosis, he is a post-surgical where tissue damage is not very much, he has no serious comorbidities. Probably my choice is usually I put them on metformin because that causes less hypoglycemia, and if he doesn't have a tendency for metabolic acidosis, it will be safe. Or if the patient is been already on other drugs like DPP or SGLT or other drugs, we can probably be restarted. But we preferably would not give drugs which would cause a risk of hypoglycemia, so that we should be careful.
Okay, thank you, madam. So to Dr. Arti, madam, how will you give sub-Q insulin therapy in patients who are on a enteral feeding by Ryle's tube in hospital settings?
As we are saying, there will be, one is basal and frequent monitoring. So one is basal, that is to be given. 50% basal out of the total requirement, and we have to frequently monitor, say 6 hourly we have to monitor, and we have to give the set dose with the correction insulin that is required as we measured previously. So that is how it is.
Okay, fine. So to Dr. Jayesh Tripathi, that how will you do discharge planning in such patients? Those who were hospitalized, treated with insulin, and now they are completely recovered and ready to go home. How will you do discharge planning?
If post ICU or critical setting, they are in the hospital for a few days, then we have time to get off insulin off their backs if possible. And if the situation demands. But if the situation demands that patient will still need an insulin, basal bolus would be the best choice for us. There are mixed data on premixes, co-formulations and basal bolus. Now, as I initially said, customization is the key.
Okay.
Now they have stopped 50-50.
Yes.
Most of these some of these companies. So we have now 70-30 only. So depending on the patient's meal pattern, his lifestyle, all the standard equations will come into play, and we have to accordingly decide on the insulin if insulin is to be given. If he's not going to be given insulin, if an established diabetic patient is there, we'll look at his previous medications for two reasons. One, whether they have worked or they have not worked. If they have not worked, then needs a change. If they have worked, then why this crisis happened and why this sugar HbA1c was so low? Do we need to add some more molecules? Accordingly, we'll add. And the most important thing is now we treat diabetes as a package. So whether we want to give something which is nephrocardioprotective in forms of SGLT or GLP something for the long-term reduction of complications and target organ damage. So depending on that, we'll decide 1, 2, 3 medications depending on the comorbid conditions, the patient's lifestyle, his timings of eating, and that is how we decide. This is guideline is okay, but this is what I do.
Okay. So I think HbA1c can also give you a some idea about
But that you'll have to you have to wait for 2 months. Again, every
No, HbA1c, admission HbA1c. Suppose somebody is having very good control with oral anti-diabetic agents and admitted for something and now recovered, you can discharge them on that previous regime also if their sugars were well controlled and were not having hypoglycemia also. So depending on admission HbA1c also you can think of continuing with insulin or insulin with OAD or only OAD depending on their previous control in patients who are already having diabetes. So now I will just touch upon, because perioperative management is a very big issue, but I just touch upon 2 or 3 things. First, I will ask Dr. Urman Bhai about how will you manage diabetes in perioperative settings, in daycare settings.
Yeah. Before going for that, never make a mistake of course, we are all fond of SGLT2 inhibitors and bound to be, they deserve to be utilized very frequently. But if there are, as Dr. Pratap rightly said, any signs of insulinopenia, HbA1c more than 10 itself is a sign of insulinopenia, losing weight, etc., etc. Any sign of insulinopenia, please do not put the patient on SGLT2 inhibitors without insulin. Right, without insulin. Coming to the, in very nutshell, we'll go through the drugs that may be given peri or pre-operatively. So most of the guidelines say, and to me, you should stop practically all drugs, preferably before surgery, OHA, and shift the patient to a basal insulin on the previous evening, a very small dose of basal insulin, and then onto the insulin, especially if the patient is going to be nil by mouth for more than 24 hours. But still there are recommendations. 2 different institutes have different recommendations, but most of them agree that metformin can be given on the day of surgery in the morning. Couple of guidelines have showed that you should stop it a day before. So metformin can be given, except the one that has been shown that if the eGFR is below 60 and if you are going to use a dye, then stop metformin immediately 24 hours prior and do not use it for next 4 days, because then there are likely to be chances of diabetic nephropathy. So metformin may be given on the day of surgery, but then you have to stop it. Same way, pioglitazone can be given on the day of surgery, but I would not venture to give it. GLP-1 receptor agonists have been given on the day of surgery. Remember, GLP-1 receptor agonist and gliptin, both, when you think about their pathophysiology, they work only if there is food. There is no food, there is no food, they would not work. So as such, you can give it if the patient is going to be nil by mouth, they are not going to work. So they are reasonably safe. The only drug that has to be very carefully done, utilized, and it is SGLT2 inhibitors. All guidelines say that 72 hours before the surgery, SGLT2 inhibitors have to be stopped. Only one guideline says it is 48 hours. Otherwise, all guidelines say 72 hours. If you do not do it, it's a criminal negligence, because guidelines have shown it. So do not make any compromise about SGLT2 inhibitors. Right?
Okay. So now I will come to Dr. Aarti Madam, that how will you manage diabetes in perioperative settings in minor and major surgical procedures?
So the most controversial
Yes.
discussion here. So RSSDI guidelines, definitely many people have given guidelines, and this is the basic chalk out of what we can do. But since we know that every patient is different, there can be n number of variations in this. These are the basic rules that we have to follow, but to individualize with the patient, this can be varied.
Okay.
So the basic first thing that we have to see, as I said, before switching also, so before perioperative also, whether the patient was, whatever he was taking, whether he was controlled on it or not, and whether it's a minor surgery or the major surgery. So minor surgery, patient was previously controlled, well controlled on whatever he was taking, we don't have to make any change. Major surgery, so as to say, if the patient needs general anesthesia for it, then we have all these things. So,
I think it will be
yes, but
exhaustive. You just give
I'll just give
glimpse of
an
it.
yeah.
Yes.
So when it is a basal, once daily, once morning hai, to morning wala, if it's a morning surgery or afternoon surgery, usually the morning dose is omitted. If it's an afternoon surgery, we can, whatever we are giving the long acting insulin, we can give half dose of it on the morning. Right? The long-acting basal doses or the long-acting doses in the evenings, whether it's a morning surgery or afternoon surgery, we can continue with the dose. And in between, the short-acting doses are omitted. We monitor the sugar 6 hourly, and we give the according to the requirement.
Okay. So correction bolus is here the key
Yes.
because the patient is not taking his nil orally, and basal is to be continued as highlighted, either reduction in the dose or the same dose. That is the key message here. So I think we have come to the end of this discussion on in-hospital management of hyperglycemia. Before I conclude, I would like to touch upon this, the most controversial aspect of using oral anti-diabetic agents in hospital settings. And there is a lot of research going on in this area, and this is a beautiful paper by a person who has done a lot of work in hospital management of hyperglycemia, that is Gugliaro, and he has written this very beautiful article that a lot of these guidelines, they are rather than on evidence, they are on expert-based recommendations or consensus statements. So still, there is no strong evidence that you have to use insulin for all patients, particularly in non-critical care settings. Critical care settings, intravenous insulin infusion, there is no doubt. You have to continue with that. But in non-critical care settings, suppose one patient who is young, who is on only DPP-4 inhibitor, metformin, SGLT2 inhibitor, no comorbidities, and is having an infected sebaceous cyst. Now you want to admit him, you want to give him antibiotics and do surgery and discharge him in 24 hours. Now is it justified to stop all his drugs, put him on a basal bolus therapy for 24 or 36 hours and then again ship them to a oral drug? So can we continue oral anti-diabetic agents in such scenarios or not? That is still controversial, but there is a lot of evidence to support the use of DPP-4 inhibitors. There are a lot of trials related to sitagliptin, linagliptin, medical settings, surgical settings, and there is enough evidence, and based on those trials, this paper has suggested this algorithm for patients with type 2 diabetes, and this is for non-critical care settings that you have to keep in mind. If it is mild hyperglycemia, patient is on less than 2 anti-diabetic agents, insulin naive, and sugar is less than 200, HbA1c good control, you can continue or you can give DPP-4 inhibitor only with correction bolus rapid acting insulin. If you are not able to reach target, then you have to add basal initially at a low dose of 0.2 to 0.3 units, and then still not controlled, then you have to go on to a full-fledged basal bolus insulin therapy. If the admission glucose is between 200 to 300, this is arbitrary because most of the trials, they have used this cutoffs 200, 300 and 400. So if they are on multiple agents, insulin already patient is on insulin, but the dose is less than 0.6. One can think of DPP-4 inhibitor with basal insulin and then with correction bolus, and if required, then one can go on a full-fledged basal bolus insulin therapy. Those who are having very high glucose, higher insulin doses, multiple agents, one can straight away start with basal bolus insulin therapy. So this is also a customization or a precision medicine approach to patients in non-critical care settings, and this is coming in a big way. And in our next that guideline revise, we are also going to touch upon when to use OADs and which OADs we can use in hospital settings. So I think team approach is must whenever you are treating hyperglycemia in hospital settings. It is a team approach. It is not only a doctor. It is medical officer, nursing staff, dietitian, relatives, everybody together, then and then they can control hyperglycemia in a proper manner in hospital settings without increasing the risk of hypoglycemia. Thank you very much. And if all of you should go through, no, I think all of you should go through this document which is available online on PubMed also, and on RSSDA platform also, that is IJDDC. This guideline is there, and anybody who is treating in hospital hyperglycemia, you go through this document. It is exhaustive, very useful for our own settings. Thank you. Thank you, everyone.